Vax. We've been doing this now for about 6 months now, I believe. So we enjoy it. We do it once a month. And my name is Dr. John O'Mani. This is Dr. Sean Peterson. We're both family doctors here in Sarnia, and we're principals with Blue Water Clinical Research Group. So tonight we're going to talk about CMV, so cytomegalovirus.
Yeah, so John, this is actually a little bit of a follow-on to one of our previous talks, talking about vaccinations. We thought we'd focus specifically on CMV. There was some discussion and questions we had after our last presentation around CMV, and we thought we'd do a dedicated session on this actual virus. Okay. And interesting enough, when we kind of started talking around and asking some of our colleagues and some of our staff, it is one of those conditions people say, I didn't know about it until either my child had it or my friend's son had it, and then they knew about it at that point. So we thought we'd dedicate a little bit of time to this discussion about CMV or cytomegalovirus and some of the vaccinations that are coming to market, or at least doing some clinical trials on, that might prevent the serious complications. And the most serious we're looking at would be what we call congenital CMV. This would be impact for the newborn baby.
Yeah, good. So, as Sean was saying, it's very prevalent in everywhere, North America especially, but it generally appears as an asymptomatic or an illness where you don't really know you have it. So you may have some very mild symptoms if you have a good immune system. For those who don't have a good immune system, it can often present with fever, weakness, sepsis, meningitis, and even death. So it's generally an asymptomatic condition in the healthy, but can be quite serious if you don't have a great immune system.
Yeah, exactly. So cytomegalovirus basically can be transmitted, as John was saying, through saliva, through respiratory droplets, contact. If I happen to have some respiratory droplets in my fingers, it can be transmitted. And we see that transmission within families as well. So from parents to children, children to parents. And as we all know, children can pass it amongst themselves quite easily, as with any other virus. And typically, as John was saying, most people don't know they've even had it. They have a cough, a cold, runny nose, red eyes. It lasts a few days, and their immune system fights off the virus. But it is possible to have latent CMV, where the CMV lies dormant, and can cause some issues at the time of pregnancy.
Yeah. So as we're saying, 50 to 80% of Canadians will have had CMV prior to the age of 40. And as we said, it's often asymptomatic, but if you have it, you may get fever, night sweats, sore throat, swollen lymph nodes. But in this day of COVID and every other mono, strep, these are very common symptoms. Flu can all feel the same way. So joints, joint muscle ache. So often, we haven't. It's not something you'd regularly test for. And prior to COVID testing, we really didn't test. We did some influenza testing and some mono testing, but we wouldn't routinely test for these viruses.
That's right. I might just say a quick pause here for a second. And after our last talk, one of my friends who's also in the medical profession reached out to me and said, "Hey, Sean, I'm not sure if you knew, but my son died of CMV." And I was aware that she'd had a child that died around early childhood, but I didn't know the circumstances. And when I had a chat with her, she says, I'm a nurse as well, and I didn't know much about it as well. Obviously, once we noticed that the child was having difficulty during the pregnancy, we then knew there was going to be a potential problem, and then it turned out to be a CMV that led to the death of the little one. And that really obviously strikes home, because that's a friend, that's a colleague, and as it turns out, out of the live births, 1 in 200 children will have been affected by CMV, and that's a high number to be out of concern. And luckily, in most of those cases, hearing loss is the predominant feature. But as we're going to see in the coming slides, it can be much more severe.
Right. Now, are the slides being shared, just so we know? Or?
The slides are being shared. They're not behind us. That's just
they can see it.
A Blue Water advertising for us, but they are being shared. It's being used through my computer. So if you're looking for the active slide, it's right there. Okay, yeah. So John, what are you seeing here?
Yeah. So this is a CAT scan of a brain of an unfortunate individual, or 3 individuals who've had CMV, or sorry, it's actually an MRI. And you can just see some calcifications in section A. You can see some calcifications and some widening of the ventricles. On the middle one, where the arrows are pointing, the volume should be going all the way to the white outer border, which is the skull. And you can see there's volume loss in the brain there. And the worst case scenario you can see on the right-hand side where there's a large part of the brain that's actually missing. And this is all from CMV that gets into the brain during pregnancy. And it's obviously catastrophic and devastating. And often you can't, especially the one on C there, it's not compatible with life often. So that's unfortunate. So that is really the worst case scenario, as we're saying. Like 1 in 200 will be born, but 1 in 5, so 20% of those will have some develop permanent hearing loss. And I've had a patient myself with the same, not the catastrophic findings, but certainly hearing loss and some other developmental delays. And again, I had a patient in the last few months also with a child born with CMV.
So as many of you likely know, John, in addition to doing primary care, also does obstetrics and deliveries as well. So obviously you can see much more in your practice there, John. And as mentioned before, it can be the mother's primary infection. That is, when we say primary, that means that the pregnant mom got the infection during the pregnancy, or it could be that chronic CMV infection that can be passed along to the newborn. So it can be either of those scenarios. Looking at these pictures here, these are some newborns born with CMV infections, and what you can see in the picture on the left there, you can see an otherwise normal appearing child, but does have multiple sort of spots or rashes, what we call macular papular, meaning it has a flat spot and also a raised component to it. The child in the middle, this is called microcephaly, basically small head, and again another abnormality secondary to the CMV virus. Yeah. And then the third picture on the right, you can see there is some we call dysmorphic feature. When we say dysmorphic, meaning it's out of the usual structure of the skull. So there's some abnormality there. You can see especially with the chin, and again the macular papular rash. So these children usually, if they're in the more severe cases of CMV when they're born, will have some identifiable features from an external perspective. They'll oftentimes have a failure to thrive, so they're not eating as well as they normally would. They might not have sufficient lung capacity to have enough oxygen on their own, so they might need to be on a ventilator for that.
Yeah, so if as you know, we have the scans. You have a 11 to 13 week scan, and you have a scan between 18 and 20 weeks. And typically you'll be picking up some of these abnormalities at the 18 to 20 week scan, especially if they have any kind of issues with anencephaly or any issues with the actual brain development. So if that were the case, and you want to prove that or to show that the mom has been infected or the baby's been infected, they can do what we call amniocentesis, where you put a needle in through the abdominal wall and you take out some fluid, and you can test that and do some viral stains to see whether there's any infection. So again, pretty rare, but it's one that would be part of the workup. If you had an abnormality in Sarnia, you'd be sent to London to the high-risk pregnancy clinic, and all these options would be discussed. Again, rare, but it does happen.
It does. The modes of transmission, we've already kind of spoke about this, but because it's droplet based, it can be through any bodily fluid can transmit the virus. And I think we've already kind of had a chat about that.
Yeah, and just all the things to do, like all viruses now, we're all washing our hands and disposing of diapers and tissues, all the usual things you need to avoid viruses. CMV is not any different from any of those.
So the question then comes up, well, we now know how prevalent CMV is. It's 1 in 200 pregnancies. Now, that's not 1 in 200 deaths, but rather just 1 in 200 pregnancies are affected by CMV. The question is, well, how do we reduce it? How do we get that number down? Because we can't immunize the baby. The baby is still in utero, so we can't immunize the baby. The question then comes up, well, what if we were to immunize women of childbearing age before they become pregnant? And if we do that immunization, does that then confer benefit to the newborns to reduce the incidence of congenital CMV? So one of the trials we're involved in is a trial where we're looking for healthy women of childbearing age who are willing to say, yes, I'm willing to step forward and be vaccinated against CMV. I know it'll have some benefit for me, but of course, it's going to have much more potential benefit for my potential future child. And then secondarily, could this also then be of benefit to all the newborns out there? I'm part of the medical group that's looking to say, can we prevent congenital CMV through my participation in a clinical trial? So with that, John, what are we looking for? Maybe to take the viewers through what is a clinical trial, and why would, in addition to what I just said, why would someone else want to get involved?
Sure. So What we do at Blue Water Clinical Research Group is we conduct these clinical trials. Everything is Health Canada approved and FDA approved, especially most of the studies we're doing are North American studies. And the trials are divided into four phases typically. Phase one is it's more kind of in the labs area. It's not really out to the general public or to kind of basically human participants. But phase two, phase three is what we generally conduct. So this is a phase three. It's a randomized, observer-blinded, placebo-controlled, meaning that half the in the particular case there's a placebo arm, so not everybody's going to get the actual vaccination. We're looking at participants between 16 and 40, and this is really for basically childborn age. It's actually Moderna virus, so that's a name that we all kind of know about. It's a Moderna vaccine. So they're doing a lot of research in the mRNA vaccinations as well. So why we do clinical trials? I mean, any drug that comes to market, any vaccine that comes to market has to go through rigorous trials. As we said, phase 1, 2, 3, 4. And these have to be done on tens of thousands of people across the world, just like we saw with COVID. They were rolled out pretty quickly, but again, there's millions of people that received the vaccines and hundreds of thousands that went through the clinical trials.
Maybe I might just pause there for a second and just talk about the type of vaccine. And we did talk about this in our talk on vaccines, but this vaccine for CMV is one of what we call the mRNA vaccines. And mRNA is a term that's is new in the last 3 years, at least in the general public knowledge. And of course, it's been discussed quite a bit about the COVID-19 vaccine. Both Moderna and Pfizer are mRNA vaccines. Now, what does that mean? Well, before we had mRNA vaccines, there would actually be a particle injected into us that looked like the virus or was the virus that was inactivated, and that our body's own immune system would then see this particle, we call it the antigen, and then form antibodies against that antigen. Instead, with mRNA vaccines, because of our ability to decode genetic codes, the lab's actually able to create a genetic sequence. And this is just a sequence of amino acids that actually codes for the particle that looks like the cytomegalovirus, but isn't the CMV virus. And this little bit of RNA gets into our cells, and they call it M for messenger. And once it's in the cell's ribosome runs the RNA through the ribosome, produces the proteins, and that gives the actual antigen that looks like CMV that our body then creates the antibodies to. Our body very quickly mops up and gets rid of this mRNA, both the mRNA little DNA strand and also the antigen, without us actually getting the CMV virus, because we actually never had the virus in us. It was just this little bit that looked like the CMV virus. So that's how mRNA vaccines work. It's using the body's own system to make a very specific protein, even more specific than we could get if we just actually use an inactivated CMV virus. So it's a pretty obviously interesting and very effective way to get vaccination.
Okay. So as we were saying in this trial, it's you're making three different basic injection days: day 1, day 57, day 169. So this trial actually goes on for 30 months, and we observe for over 30 months. As we said, there's also a placebo arm, and most of these studies will have a placebo arm because if there's any side effects from that are reported, we got to make sure is it the same in both the placebo and the active arms.
Yeah, you bring up a good point there, John. That the reason there's two arms, you said the one aspect was the safety component. So we want to make sure that the vaccine is safe, there's no untoward or unexpected side effects, but also equally, we also want to show efficacy. So in the trial, we want to show that those that had the CMV vaccination, that their antibody levels that are measured in the trial, we call them the titers, have climbed up. And of course, we also measure those that had the placebo, and we would expect that they would not form antibodies to CMV because they've not been exposed to the vaccine.
Yep, and we also make sure you're actually protected against the CMV as well. So if people are getting the infections, even if it's asymptomatic, that can be picked up as well. So is it actually working?
Yeah.
So what we call the inclusion criteria. So if somebody's interested in the trial, and we hope people will be interested in this trial, before we start, we'll do a blood test to make sure that you haven't already been exposed. As we said, there's a large percentage of the population over the age of 40 who've been exposed. So we want to see if you're seronegative, meaning you've never been exposed. You have to be a female between 16 and 40, so what we call our childbearing age, overall good health, BMI between 15 and 35, and you can't be pregnant, obviously, when we do this study, right? So that's something that's important for that.
In my OCD tendencies here, I'm just noticing I made a mistake in the BMI. I just showed kilograms. It's actually kilograms per meter squared. So, body mass up to 35. That for most of us, that means being under probably about 220 would get us in that category.
Yep. And then obviously exclusion, pretty much the opposite of what we just said. The inclusion, if you're not of childbearing age, or you've had hysterectomy, tubal ligation, you have any unstable medical conditions, if you've donated blood within the last 28 days of screening, or if you've ever had a CMV vaccine. So we don't expect that to be the case here in Sarnia, because this is the first study that we've ever done based on CMV. So for us, we're excited. It is a if you speak to the general public, they don't know a lot about CMV. So part of what we're talking about today is not just for this vaccine trial we're doing, but just to educate people on CMV, just show really the prevalence of it. We don't want to be scaring people that this is something now. It's been around for many years. On our side, we've seen quite a bit of it. We see patients, and sometimes there's unwanted. Babies are born sick, and maybe they don't find out it's a CMV infection as well. So we definitely know that it's a common virus that's out there, and like all viruses, we're looking to see if we can find a vaccination and some protection for those most at risk.
And along those same lines, this is not currently part of the publicly funded vaccination schedule, so none of us would have immunity from vaccination from our childhood vaccines. So that's why it's also important to look at this as well.
Yeah.
So we'll probably pause there and just see if there's any questions from our audience that we can address. And while we're sort of collecting those different questions, just remind you that on Thursday, April 28th, we'll be back again at 7 p.m. same time for another discussion. We have yet to pick the topic, but we're going to be sending it out by Facebook as soon as we have that sorted out there in the next week or two.
So I have a clarification request. Somebody just wanted to make sure that they understood it correctly. Is this something that happens during pregnancy that affects the baby for the rest of their life?
Sure. So I'll repeat the question. So the question was, is a CMV infection that something happens during pregnancy to affect the rest of the life of the child?
So if you have it, so we know that 1 in 200 births will have a child who's been infected with CMV, but only 1 in 5 will have something that's like a permanent serious outcome. So the most common would be a problem with your hearing. So that can be 1 in 5 of those patients will have that, and that is a lifelong problem, right? So that's something. And the most severe cases, again, when you see the brain involvement, that's not reversible, unfortunately. So yes, it is. Most people do not have an issue with it, and the babies will be healthy, just like we are being asymptomatic. There's an unfortunate few that will have long-term sequelae.
And with those statistics, so if 1 in 200 is born with CMV, that means out of those, out of that whole group, as John was saying, it's a smaller percentage. Only 20 out of 100 would actually have any hearing loss. Even that hearing loss would be on anything from a gradual hearing loss or mild to severe. And of course, the severe cases that we showed here would still be relatively rare, but they're not zero.
Is this something that the baby could catch later on, like after birth?
Yeah, so the question is this a virus that the baby could catch after birth?
Yeah, and that's really why we're saying up to 80% of people will have antibodies who've been exposed by the age of 40. So it's being picked up at some point in your life. If your mom has it and you're kissing your baby or anything like that, it's this goes around daycares. We just don't. That's something we test for, and the children were often asymptomatic. So,
and it's one of the viruses that we test for when we have a patient presenting with sort of a unique set of constellation of symptoms that really are neurologic. So when someone presents them, it's not within the realm of our usual family medicine world. We start thinking about, well, what are the other, we call the weird and wonderfuls? And CMV is one of them. West Nile virus, CMV, HIV. We start thinking more broadly, is this something else going on that we don't routinely see that we need to do some special testing for? CMV would be one of them. As well, we also test for it in some of the children and adult population that have meningitis that's not bacterial. We oftentimes look for CMV meningitis as well. So still uncommon, but we can get it and it can affect us later in life.
And how would you diagnose it before birth? CMV?
So the question is, how would you diagnose this pre-birth?
Yeah. So again, it's not a test we'd normally do, but if we did, we do serology. So you look for antibodies. And that's more to see if you've been exposed. Active infection, again, you can look for certain antigens and antibodies as well.
Yeah, and I guess you could either test mom or
Yeah.
you could test the amniocentesis.
Yes.
Yeah.
Would you recommend it for your family?
So good question. So the question is, would we recommend the CMV vaccine for our family?
Yeah. So we ask that question every time we accept a clinical trial, and we don't accept trials that we wouldn't have a family member in. Now, being principals or PIs in a study, we're not allowed to enroll our family members in a clinical trial. But that's the kind of question that we always ask ourselves, and the answer for this would be yes.
Yeah, and that's the question I've been asked quite a bit as well, even around other vaccinations, specifically with COVID. Hey, Dr. Peterson, you have a 9-year-old, 10-year-old. Have you vaccinated them? Yeah, I have. So I like that question because you can tell me one thing, doc, but in your heart of hearts, are you really committed to this? And the answer is yes. I would enroll. If I had a family member that wanted to participate in this trial, I would say, here's the risks, here's the benefits, and I'd suggest that you strongly consider doing this trial.
Yeah. That's a question I get almost every day with flu vaccines for kids. So we introduce them at 6 months of age, and they're like, "Really, at 6 months? Did you do it for your own kids?" And the answer was always yes as well. So
yeah.
So we talked about how long this specific trial is. Is there follow-up to follow the children that are going to be born after receiving this vaccine?
So the question again is, the study participants are the women of childbearing age, and the question is the study specifically also following any potential babies born during the trial or after they receive the virus in this trial?
I mean, it wouldn't be part of the trial. It'd be something that'd be obviously monitored, and the family doctor or pediatrician or primary care provider would be notified. But typically that wouldn't be part of the trial, but that'd be something we'd be made aware of, and that'd be considered an event that would be followed.
Now, along those lines, there might be a subsequent trial coming that will be looking at that specific question, but that's not part of this trial. This trial is really answering the question of, if we vaccinate healthy women of childbearing age, do they mount an immune response that shows that they have immunity against CMV? That's really what this study is answering the question to. But the individual that asked that question on our chat is obviously very astute in saying, okay, well, what's the next step? Okay, well, what about the babes? What's the long-term outcome? And that's obviously the next trial.
And that is, what exactly is the trial measuring?
So the question is, what exactly is the trial measuring? That is, what are the primary outcomes from the trial?
Yeah. So just as Dr. Peterson was saying, we just want to see, are you mounting an immune response? So by getting the vaccine, are you actually developing the antibodies, and are you reducing the incidence of the actual virus? So are you decreasing the chance of getting it compared to the placebo arm?
Yeah.
So
now, as a secondary objective, the trial will also, as Dr. Manny already mentioned, we'll also assess those that get viral responses. Is it CMV? That might be a secondary objective of the trial as well, but that's not the primary objective. The primary objective is just determining, does the individual who received the vaccine, do they mount the immune response to form the antibodies?
Yeah. Then for all of our clinical trials, we always reimburse our participants for their time. It's not, people don't do clinical trials for the financial reimbursement, but for your time, everybody is reimbursed for the time, $50 to come in for your visit, and that's important. We want to respect your time, and it's not like you're sitting in the doctor's office for hours and hours. We make a priority to keep it moving.
Yeah,
so I hope people ask.
Yeah, no, I hope everyone's enjoyed this talk, and please provide us some feedback, whether it be in the chat for this talk today or send us a message through Facebook. We are going to be trying to increase the frequency of our talks, either through our research website or also through our own individual practices as well as we move forward, just to try to continue to expand and grow the knowledge translation. We really enjoy these sessions because it allows us to sit down and have a chat about a condition that we can spend half an hour having a chat about. And that's very different than the office where patients are in to see us and we feel pressured because we have another 50 patients yet to see for the day. And this is a nice way to have that knowledge translation. So we thank all of you for being here tonight.
Yeah, thank you.